Hello friends, let's start Haematology Revision Express, which is a part of Pathology. I will be dealing here. So initially we will be dealing with the basic of hemat, that is anemia. Okay, anemia. So how you are going to define anemia? Anemia is reduction in the total circulating red cell mass or the hemoglobin. Okay, that's called as anemia. So we are going to classify anemia based on its mechanism, that is how is it caused, and next is based on the morphology. So based on mechanism, it is of three types, that is due to blood loss. In blood loss you have two types, acute blood loss and chronic blood loss, which may be due to trauma or bleeding. The next one is increased destruction. The examples under them are hereditary spherocytosis, glucose 6 phosphate deficiency, sickle cell anemia, and paroxysmal nocturnal hemoglobinuria, that is PNH. Okay. Then the third one is decreased production. So there is some quality, not quality, that is quantity problem, that is called as thalassemia, megaloblastic, iron deficiency. Okay, these are based on the mechanism. So these are based on the mechanism. The next we are going to deal with is based on morphology. Based on morphology, you are going to divide it as normocytic, microcytic, macrocytic. So what are the causes of normocytic anemia? That is, the RBCs are in normal size and shape and the color. Okay, that's called as normocytic normochromic anemia. So basically the examples under them are aplastic anemia, acute blood loss. Okay, these are the things. In microcytic you are going to see Sita. What is the mnemonic? That is Sita. So what are the examples under them? Sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia due to chronic disease. These are the things which come under microcytic anemia. So let's move on to macrocytic anemia. In macrocytic anemia, mainly we are going to see megaloblastic anemia. So what are the clinical features of anemia? So some of the features are common. They are common clinical features such as fatigue, malaise, breathlessness, pale conjunctiva, and edema in the late stage due to failure. Okay. Here we are going to see the cardiac failure. Because of this, they develop edema in the legs. That's called as pedal edema. So what is very specific for iron deficiency anemia? For iron deficiency anemia, we are going to see the koilonychia, that is called as spoon-shaped nails. Whereas in case of megaloblastic anemia, you are going to see the hyperpigmented knuckles. Okay, you are going to see the hyperpigmented knuckles. So now let's start about iron deficiency anemia. In case of iron deficiency anemia, what are the causes? The cause of iron deficiency anemia are lack of dietary intake, that is due to poverty and lower socioeconomic status. The next one is impaired absorption, that is due to gastrectomy, some surgery, or some malabsorption syndrome such as celiac disease. The next one is increased requirement. So some people will be requiring more iron and you will be giving less iron. Such states are like growing child and pregnancy. All these are requiring more iron. Okay. Next you are going to see chronic blood loss. Because of chronic blood loss such as hemorrhage, bleeding in GIT or in genitourinary tract, because of all this you are going to precipitate into anemia. So how are you going to deal with the pathogenesis? So what is the pathogenesis of iron deficiency anemia? The pathogenesis of iron deficiency anemia is there will be some cause that has led to the blood loss or decreased intake, or there is an increased destruction. All these causes, they gradually what they do, first the body will be having the storage iron. Okay, that storage iron will be normal, and even this serum iron and transferrin also will be normal. As the time passes, gradually the storage will start decreasing and there is a decrease in serum ferritin. So decrease in serum ferritin is the most sensitive marker of iron deficiency anemia. With normal serum iron and transferrin, here the serum iron and transferrins are normal, whereas as the time passes in the near future, you are going to see decrease in the serum iron and transferrin levels also. You are going to see the decrease in serum iron and transferrin saturation. With bone marrow hypercellularity, to compensate this, the bone marrow is working more, so that the bone marrow is becoming hypercellular. After this, the last resort is you are going to develop the anemia. So what is the type of anemia because of iron deficiency? It is microcytic hypochromic RBCs are seen, that is microcytic hypochromic anemia is the result of iron deficiency. Okay, next we will be dealing with the morphology. Okay, we will be dealing with the morphology. So in morphology, basically on peripheral smear what you are going to see, and on bone marrow what you are going to see. On peripheral smear you are going to see microcytic hypochromic RBCs, anisopoikilocytosis, that is difference in shape and size. Okay, that is called as anisopoikilocytosis. Then pencil cells and target cells. Okay, so we are going to see the diagram now itself, so it will be easy for you. See, this is what the peripheral smear is. In peripheral smear, you are going to see pencil cells, some broad like cells, they are called as pencil cells. Then you are going to see the nucleated like RBCs, they are called as target cells. And you are going to see the microcytic hypochromic RBCs, which are dim in color and small in size, they are called as microcytic hypochromic RBCs. Okay. Next we will be dealing with bone marrow. In bone marrow you are going to see more of erythroid progenitors. To synthesis this RBCs, the bone marrow is working more. So because of that, the erythroid progenitors are increased in case of bone marrow aspiration. With lack of iron filled macrophages in bone marrow, you are going to see the macrophages. In that macrophages you are going to see less iron because iron is deficient. So iron is seen less. This is seen in case of Persian blue stain, okay, not in normal stain. This type of iron is seen only in case of Persian blue stain, which is going to stain the iron. So what are the lab investigations? In lab investigations, everything is reduced most of the times. That is HB is reduced, MCV is reduced, MCH is reduced, MCHC is reduced, serum ferritin is reduced, and transferrin saturation is also reduced. So what is increased? RDW, that is red cell distribution width, is increased, and TIBC is increased. Okay, so retic count will be decreased or normal in case of untreated cases, not in case of treated cases. If it is treated, then you are going to see more retic because the patient is responding. Mainly retic count is done for the detection of successful treatment, whether the treatment is working for the patient or not. For that cases you are going to do the retic count. So what is the treatment here for iron deficiency anemia? For iron deficiency anemia, you are going to do what? Iron, oral iron and parenteral iron. These are the two forms you are going to give. For oral iron, you are going to give ferrous fumarate and ferrous sulfate. For parenteral iron, most commonly used is iron sucrose. Okay. So this is what about iron deficiency anemia. Next we will be moving with megaloblastic anemia. So what you are going to, how you are going to define megaloblastic anemia? Megaloblastic anemia is a type of anemia which has been caused due to deficiency of vitamin B12 or vitamin B9 due to defective DNA maturation. So you are going to see defective DNA maturation. This is very important here. That is called as megaloblastic anemia. If there is no DNA maturation defect, then it is called as non-megaloblastic anemia. So if there must be a DNA maturation defect to call it as megaloblastic anemia. So what are the causes of megaloblastic anemia? The causes mainly vitamin B12 deficiency and vitamin B9 deficiency. So B9 deficiency and B12 deficiency. B12 deficiency is because of decrease in intake, that is inadequate diet. Same way here, B9, inadequate diet, same here. B12, it is associated with only veg diet, only veg they are going to eat, only veg. Vegetarian people will be having more probability to get the vitamin B12 deficiency. So impaired absorption in case of intrinsic factor deficiency, okay, intrinsic factor deficiency, gastrectomy, malabsorption diseases in the GIT, all this will contribute to vitamin B12 deficiency. Whereas vitamin B9, it is again due to decreased intake, inadequate diet, alcohol. Okay, the people who is on alcohol will be having the defect of vitamin B9. Or there is increased requirement. There is increased requirement, such as in case of pregnancy and infancy. Okay. Next, impaired absorption. Same way here has like that malabsorption disease. Okay, increased loss such as hemodialysis. Okay, in case of hemodialysis, there is increased loss. So pathogenesis. What about the pathogenesis here? In case of pathogenesis, there is a deficiency of vitamins, that is B9 and B12. Okay, B9 or B12, there is a deficiency vitamins that will lead to defective nuclear maturation. If there is a defective nuclear maturation, then there is inadequate DNA synthesis. Because of this, what happens? There is decrease in the cell division. So if there is a decrease in the cell division, then what happens in further is there is a formation of abnormal cells. Instead of forming a normal cell division, abnormal cells will increase, and there is ineffective erythropoiesis. Okay, there is no synthesis of the RBCs also if there is no cell division. So on the prolonged course, what happens is there is accumulation of methylmalonate and abnormal fatty acids. Okay, methylmalonate and abnormal fatty acids, because the enzymes required for them is defective. So these products accumulate in the body, and they will lead to neurological symptoms or complications in megaloblastic anemia. This is why in case of vitamin B12 deficiency, you are going to see the neurological defects. Okay. Now we will deal with the morphology, that is the peripheral smear. In case of peripheral smear, mainly you are going to see pancytopenia, that is decrease in RBC, WBC and platelets. Okay, you are going to see all these are decreased. Whereas in case of macrocytic anemia, that is megaloblastic anemia, you are going to see mainly macrocytic RBCs. Okay, they are huge RBCs, or macroovulocyte. It's called as macroovulocyte also. Sometimes it will be oval, they are called as macroovulocytes, and hypersegmented neutrophils. Okay, hypersegmented neutrophils. So what happens to the retic count here? In case of iron deficiency anemia, what was the retic count? Retic count may be increased, it may be decreased or normal, whereas here it is always decreased. Okay, it is always decreased. So the patient will have reticulocytopenia. Here in the history they will mention it is reticulocytopenia, don't forget. Whereas in case of bone marrow, it is hypercellular. What about the RBCs in bone marrow? They are deeply basophilic cytoplasm with fine chromatin and prominent nucleoli. It is gold standard. Okay, RBCs. So WBC, you are going to see giant metamyelocytes and band forms are seen. Whereas platelets, in case of platelets, you are going to see giant megakaryocytes. There are huge. Okay, everything looks huge on bone marrow aspiration. That is what you are going to remember. So next about the diagnosis and the treatment. So in case of diagnosis, what happens is, first I have told you that is pancytopenia, and there is decrease in HB, whereas MCV is increased here. Okay, MCV and MCH is increased, whereas normal MCHC. Okay, normal MCHC. Retic count is always decreased. Never forget the retic count is decreased, and increased Figlu. Okay, there is some product called as Figlu. It is present in our body. Okay, if there is a vitamin B9 and vitamin B12 deficiency, you are going to see increased Figlu excretion. Okay, next is increased indirect bilirubin, because the RBCs are breaking down because of some instability. Then that will lead to indirect bilirubin. Then there is increased LDH. Then you are going to see serum homocysteine levels and serum methylmalonic acid. These are the items which are increased. Okay, very specific for vitamin B12 deficiency. So how you are going to treat? Basically, you are going to supplement them first. So what you are going to do? You are going to supplement them, like supplement folic acid and supplement vitamin B12. Okay, either it can be given naturally. Naturally, it is the best compared to the artificial supplements. Okay. Next we will deal about sickle cell anemia. So what is sickle cell anemia? Sickle cell anemia is a group of commonly inherited hemoglobinopathic disorder due to point mutation. In the beta globin chain. There is a point mutation. In case of beta globin chain. What is the genetic here? Point mutation at 6th place, that is glutamate replaces the valine. Okay, glutamate replaced by valine. Okay, that's called as sickle cell anemia. So in case of normal adult hemoglobin, you are going to see the glutamate that will be replaced by the valine, and that will lead to formation of HbS. So pathogenesis, basically HbA normally is seen because of deoxygenation. You are going to convert them into HbS. They are called as sickle cells. So what the sickle cells will do? They cause sickle cell disease, that is called as SCD, that is called as sickle cell disease. So what will this sickle cell disease further lead to? Hemolysis. Okay, because of this the patient will present into anemia, that is hemolytic anemia, and you are going to see the sickle cell are going to block the small vessels. That will lead to microvascular occlusion. So what are the clinical features? Clinical features mainly you're going to see moderate to severe anemia, and there is something called as vaso-occlusive crisis. Okay, vaso-occlusive crisis, sequestration crisis, and aplastic crisis. These are the crises, and based on them you're going to tell about the symptoms. Vaso-occlusive crisis, you're going to tell about dactylitis, that is pain in hands, extremities, especially hands and foots. You're going to see pain, that's called as dactylitis. Then acute chest syndrome, because of some breathlessness or chest pain you're going to complain. And priapism, what is priapism? Priapism is called as painful erections. Okay, then sequestration crisis. In case of sequestration crisis, you're going to tell about the splenomegaly. Why this sequestration crisis? These sickle cells, what they do, they're going to sequestrate inside the spleen, and they cause blockade of the splenic vessels. Okay, and they lead to splenomegaly, and it is associated with hypovolemia and shock. Then aplastic crisis. For this to happen, there must be a parvo B19 infection. It's a virus. Okay, parvovirus B19 infection. There is a sudden decrease in the HB, and it's an emergency. Okay, and it's an emergency. So next, we're going to tell about the morphology. In morphology, basically peripheral smear, sickle cells. You're going to see mainly sickle cells. You're going to see these are the sickle shaped cells, so they are called as sickle cells. And reticulocytosis, nucleated RBCs, target cells, and Havel gel bodies are seen in case of sickle cell anemia peripheral smear. So on diagnosis, that is laboratory diagnosis, X-ray. On X-ray, you're going to see crew cut appearance or hair on end appearance, especially seen in skull. Okay. Then meta-bisulfate test, which is used for screening, that is seen. Okay, that test will be positive. Then gold standard is hemoglobin electrophoresis and HPLC. These two are gold standard. You're going to see HBS band there. And what is the beauty of this particular sickle cell anemia is it can be diagnosed prenatally via amniocentesis and chorionic villus sampling. Okay, it is usually done in the 11 to 13 weeks of gestation and 18 to 20 weeks of gestation, that is CVS, chorionic villus sampling, whereas amniocentesis is done very early, that is 11 to 13 weeks. You're going to diagnose the patient using the amniotic fluid. Okay, so what is the treatment? Basically here the drug used is hydroxyurea. What these drugs do, they inhibit the DNA synthesis and they increase hemoglobin of fetal side. Okay, they increase the HPF. Okay, not HPS. Instead of decreasing, it increases the HPF, so that it will be helpful, so that the hemoglobin F is converted to a normal adult hemoglobin rather than converting it into HbS. So it is all about the sickle cell anemia. Okay, now we will start hereditary spherocytosis. So hereditary spherocytosis is defined as inherited hemolytic disorder with intrinsic defect of RBCs, shape and membrane. That is called as, there is some intrinsic defect itself. There is some intrinsic defect that has led to the RBCs, shape and membrane defect. So what is the pathogenesis? Basically the pathogenesis is the intrinsic defect. So what is the intrinsic defect there? There is a defect in ankyrin, spectrin, band 3, band 4.2 or 4.1 and actin. These are the proteins which will be defective in case of HS. So what happens if these are defective? There is a reduced density of membrane skeleton and lipid destabilization. The RBC's lipid membrane will be destabilized and the membrane skeleton which forms the membrane of that particular RBCs is going to be weak, or that is less dense. Because of this, what happens? There is a decreased surface area and formation of spherocytes These spherocytes, what they do, they sequestrate in the spleen and they cause extravascular hemorrhage. If there is any hemorrhage occurring within the blood vessel, that is called as intravascular hemorrhage. If there is any hemorrhage which is occurring in the spleen, it's called as extravascular hemorrhage. So morphology, what you're going to see, there are n number of microspherocytes. Okay, n number of microspherocytes. If you're going to stain with higher stains like Giemsa and Romanowski stains, you're going to see the reticulocytosis. That is increase in the retic count. What are the clinical features here? anemia, splenomegaly because of sequestration of the RBCs there, and jaundice because of destruction of RBC, that is hemolytic anemia, and it is associated with gallstones. It is associated with gallstones. So what is the lab diagnosis? Basically the lab diagnosis most commonly seen is because of osmotic fragility test. Okay, osmotic fragility test. So this test is positive in case of HS. This test indicates there is an early hemolysis due to fragile RBCs. Usually the hemolysis occurs at the 0.5% of NaCl, but in case of HS at 0.7 to 0.8% itself you are going to see the hemolysis. That indicates the test is positive. Next we will deal about beta thalassemia. Beta thalassemia. So beta thalassemia is a group of syndrome of inherited diseases due to deficiency of beta globin chain of hemoglobin adult chain. Okay, in hemoglobin A, that is adult hemoglobin, the beta globin chain is reduced. Because of that it is going to cause the beta thalassemia. If there is a decrease in alpha chain, then it will cause alpha thalassemia. In beta chain there is a deficiency of beta chains, there is a deficiency of beta globin chains, whereas there is excess of alpha chains, So what is the pathogenesis? Usually in the normal hemoglobin, that is alpha to beta 2, there is due to some quantitative defect, there is a decrease in the beta chain, and increase in the alpha chain. Because of this what happens, there is an abnormal erythroblast formation, where you are going to see decreased beta chains and there is an aggregation of alpha globins. Because of this what happens, ineffective erythropoiesis, and some of these erythropoietic cells, that is few RBCs, they escape and they will be leading to cause extravascular hemolysis, and because of this hemolysis anemia is caused, and because of this ineffective erythropoiesis anemia is caused, and because of this abnormal erythroblast anemia is caused. So basically in beta thalassemia anemia is due to three causes. What are the three causes? One is abnormal erythroblast production, the next is ineffective erythropoiesis because of abnormal erythroblast, and the third cause is extravascular hemolysis. These are the three causes which will lead to anemia in case of beta thalassemia. So after anemia is caused, you are going to do the repeated blood transfusion. Because of this repeated blood transfusion, what happens is they are going to see iron overload. Iron overload is seen. And anemia, there is a decrease in the hemoglobin concentration. So hemoglobin will be carrying the oxygen. So there is tissue hypoxia. If there is a tissue hypoxia, what happens is bone marrow is going to expand and work more, and because of this what happens, there is a skeletal deformities. That is why you are going to see the hemolytic phases in case of beta thalassemia, thalassemic phases, or beta or hemolytic phases it's called as. Okay, so what are the clinical features? Facial deformities, just now I told, right? Facial deformities like hemolytic phases, that is frontal bossing and maxillary cheekbones become prominent, and there is a facial puffiness, all this, and flushing, all this happens in case of facial abnormalities or deformities. And hepatosplenomegaly because of EVH. Because of this EVH, that is extravascular hemolysis, the spleen is enlarged, and hepatomegaly is because of the iron overload. Because of this iron overload, there is increase in liver size, and together it's called as hepatosplenomegaly. On X-ray, you are going to see crew cut and hair on end appearance here also. Okay. So the morphology. In morphology, since beta thalassemia being a microcytic hypochromic anemia, same features are seen here, like that is target cells and microcytic hypochromic RBCs, and basophilic stiffening is uniquely seen here. Okay, basophilic stiffening. Next, the lab diagnosis. Basically, in the lab diagnosis, you are going to see serum iron, serum ferritin, and TIBC all are decreased. Okay, serum iron, serum ferritin, TIBC is decreased. Whereas there are two parameters which are going to differentiate it from the iron deficiency anemia, that is RDW and Menzel's index. These two are the ones which are going to differentiate thalassemia from the iron deficiency anemia. In case of RDW, the RDW is normal, whereas in case of iron deficiency anemia, it is increased because of anisopoikilocytosis. Whereas Menzel's index, it is less than 13 here, there it is more than 13. Okay, what is Menzel's index? It is MCV by RCB count. Okay, it is MCV by RBC count. So what is the treatment? Being an RCB fan, it happens. Okay, so RBC count Okay, it's also considered in case of Menzel's index. So what is the treatment here? Blood transfusion. Okay, the treatment is blood transfusion. Next, we'll deal about the platelet disorders. In the platelet disorders, we're going to first cover is von Willebrand's disease, which is important. Okay, von Willebrand's disease is the most common inherited bleeding disorder, usually heterogeneous hemorrhagic disorder caused by the deficiency or the dysfunction of von Willebrand's factor. Okay, von Willebrand's factor is defective or deficient or dysfunctional, which has led to this inherited bleeding disorder, which is clinically heterogeneous hemorrhagic disorder. Okay, so what are the types in case of von Willebrand's disease? There are three types: type 1, type 2, type 3. In case of type 1 and type 3, there is a qualitative defect, whereas in case of type 2, it is qualitative defects complete. Okay, here there is defects, whereas in case of type 1 and type 3, it is deficiency. It is deficiency. Sorry, I pronounced it wrongly. That is first and third you're going to see the deficiency, whereas in case of second you're going to see the qualitative defects. There is something called as acquired von Willebrand's disease. That is, some antibodies are produced for von Willebrand's factor that will lead to acquired von Willebrand's disease. So what is the lab diagnostic features? Platelet counts are usually normal, bleeding time is increased, that is prothrombin time is normal, whereas APTT is increased and von Willebrand's factor is decreased. Okay, APTT is increased because the long pathway, that is what, intrinsic pathway, where there is a factor 8 involvement, and because of this APTT is prolonged because of factor 8 deficiency. What is the treatment? Treatment is desmopressin. I don't know for what reason they are going to give desmopressin. The next is recombinant von Willebrand's factor can be given, or even factor 8 transmission can be given. Okay. Next, what are the causes of thrombocytopenia? That has been asked for you for 3 marks. So there is impaired production. In case of impaired production, that is alcohol, HIV, vitamin B12 deficiency, vitamin B9 deficiency, aplastic anemia, and MDS. These are the causes. Okay. Next is accelerated destruction because of some immune related cause. Okay, or idiopathic thrombocytopenic purpura, and DIC, that is disseminated intravascular coagulation. There is erasement of entire clotting factors. Next is splenic sequestration that has led to the hypersplenism, and dilution of platelets, that is because of massive transfusion of old stored blood. Because of that also thrombocytopenia can occur. Next we'll go for Hodgkin's lymphoma. Hodgkin's lymphoma. We have entered into WBC now. We are going to deal with WBC disorders. So what is the definition of Hodgkin's lymphoma? Hodgkin's lymphoma, they are the lymphomas which are large heterogeneous group of malignant neoplasms originating primarily from lymphoid tissues. Okay, lymphomas which are large heterogeneous group of malignant neoplasms originating basically primarily from lymphoid tissue. It's called as lymphoma. So there are 2 types of lymphomas. One is Hodgkin's lymphoma, other means non-Hodgkin's lymphoma. So we are going to deal with Hodgkin's lymphoma here. In Hodgkin's lymphoma, what is the predisposing factors, or what are the epidemiology? That is males more than females. Okay, males will be affected more than females. Then it is bimodal distribution. Usually it is seen in young adults, that is 15 to 19 years, and old age more than 55 years. What is the cause? 30% of the Hodgkin's lymphoma cases are associated with EBV. Okay, it is associated with EBV, and there is 1% history of genetic. Okay, 1% history of genetic is present. Pathogenesis. So what happens in the pathogenesis? This EBV infection, because of expression of LMP1 and NFKB, kappa beta nuclear factor, that is transcription factor. It's a transcription factor that has led to the conversion of a normal B cell into an RS cell, that is Reed-Sternberg cell. It's called as RS cell, Reed-Sternberg cell, which are a hallmark of Hodgkin's lymphoma. What these RS cells will do, they lose the capacity to get into apoptosis. Okay, there is loss of apoptosis, and they release unwanted excessive cytokines like IL-5, IL-10 and MCF. Okay, and they cause the further inflammatory related response. So what are the clinical features you are going to see here? Clinical features mainly painless lymphadenopathy. Most commonly it is unilateral and it is cervical. Okay, in the neck you are going to see. Then it is anemia. Okay, anemia like pallor, all those things you are going to see. Weight loss, fatigue, fever. These are all the constitutional symptoms. There is a specific pattern of fever in case of Hodgkin's lymphoma, that is called as Bell-Epstein fever. That is, for the first 2 weeks the fever will increase, and for the next 2 weeks the fever will decrease. That is it's called as 14-day fever also. Others, what you're going to see is breathlessness or cough. If there is a large mediastinal mass, if it is involving large mediastinal mass, then you're going to see the breathlessness or cough. So what is the lab diagnosis here? In case of lab diagnosis, the CBC will reveal anemia, lymphopenia. You're going to see a decrease in the lymphocytes, lymphopenia, neutrophilia and eosinophilia is seen, whereas lymphopenia is seen. ESR and LDH, they are the markers of poor prognosis. If they are going to increase, it indicates there is a poor prognosis of this particular disease. You are going to test for HIV here, because most of the Hodgkin's lymphoma is common in case of immunocompromised states. Okay, and EBV infection is also common with HIV. So to differentiate clinical and non-clinical Hodgkin's lymphoma, what you are going to do? CD20 marker is there. If it is positive, if the CD20 marker is positive, it is non-clinical. If it is negative, it is classical or clinical. Okay, it is most commonly encountered. It is classical. So what is the classification? Based on the WHO, you are going to classify Hodgkin's lymphoma into 5 types. That is nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. The last one is nodular lymphocyte predominant. It's a non-classical variety, NLPHL. It is called as NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma. That is non-classical, whereas the others are classical. So morphology. See, this is what you are going to see on the peripheral smear. The RS cells, they are very different for each and every disease. Classic RS cell, it is seen in most of the Hodgkin's lymphoma. So that is called as classic Reed-Sternberg cell. So mononuclear is seen in case of mixed cellularity and lymphocyte rich. Whereas lacunar, it is seen in nodular sclerosis. And popcorn, it is seen in NLPHL, that is non-lymphocyte predominant Hodgkin's lymphoma. So the treatment here basically is radiotherapy, chemotherapy, and the gold standard is hematopoietic stem cell treatment, transplantation. Okay, that is a treatment of choice. So next we'll deal with multiple myeloma. So what is multiple myeloma? It is a plasma cell neoplasm characterized by formation of multifocal tumor masses at multiple locations. Okay, it is a plasma cell neoplasm characterized by formation of multifocal tumor masses at multiple locations. So pathogenesis, basically the pathogenesis is mainly due to translocation of 1114. There is a translocation of aberration of chromosomal aberration, that is called as translocation 1114, that has led to the formation of plasma cells. If these plasma cells increase so abnormally, what will that lead to? What is the fate of them? There is an increase in abnormal immunoglobulins. There is increase in abnormal immunoglobulins. There is increase in light chains. There is activation of MIP-1 alpha. So what are these fates? If there is an increase in abnormal immunoglobulins, what that will lead to? That will lead to infections. Whereas increased light chains, what they do? These light chains, they are called as Benz-Jones proteins. They accumulate inside the kidney and they cause the renal failure. And the renal failure, because of the deficiency of erythropoietin, will lead to anemia. Whereas activation of MIP-1 alpha, what does it do? It stimulates the osteoclast. After stimulating the osteoclast, that will lead to bone resorption. Because of this bone resorption, the calcium which is present inside the bone will come out, and that will lead to increase in the serum calcium and punched out skull lesions on the X-ray. These are the punched out lesions on the skull X-ray. Next, the morphology. You are not going to diagnose the multiple myeloma on the peripheral smear, because you're just going to see the Rolex formation. Whereas bone marrow, you're going to see the plasma cells. Okay, 30% of plasma cells with hypercellularity. There are different types of multiple myeloma cells. They are called as flame cells, Mott cells, Russell bodies and Dutcher bodies. Okay, flame cells, it has if there is some fire coming out of the cell, that's called as flame cell. Mott cells are something called as black mottling, bluish mottling. Okay, that's called as Mott cell. Whereas Russell bodies, they are intracytoplasmic inclusions. Whereas Dutcher bodies, you're going to see the intranuclear. Whereas Dutcher is intranuclear, Russell is intracytoplasmic body. What is the treatment of multiple myeloma? The treatment of multiple myeloma is proteasome inhibitors such as bortezomib. It was the first drug which was invented to treat the multiple myeloma. Then thalidomide can inhibit the multiple myeloma, but it's not clinically approved. It is just as a part of theory knowledge, you must know. Then bisphosphonates, they're going to decrease the bone resorption and help them to live. Okay. So clinical features, sorry, I forgot to tell about the clinical features. Clinical features, you're going to see pallor, okay, because of anemia, and fatigue because of anemia, repeated infections because of increased abnormal immunoglobulins, and bone pains and repeated fractures because of activation of osteoclasts, and renal failure again because of increased light chain production, and facial edema is seen because of renal failure. So how are you going to diagnose basically? What is the diagnosis? How are you going to diagnose? The HP is decreased here, but it is normocytic normochromic anemia. It is of normal variety. The serum calcium is increased and the serum creatinine is also increased because of renal failure, and Bence-Jones proteins are accumulated inside and they are also increased. And on HbE you are going to see the M band. On HbE you are going to see, that is hemoglobin electrophoresis, there is a separate band called as M band because of M component which is being created by multiple myeloma. So they are going to ask, what are these Bence-Jones proteins? We are going to tell they are light chains of immunoglobulins which precipitate at 40 to 60 degrees Celsius and they disappear at 100 degrees Celsius. Once you are going to cool them, they reappear. Okay, they reappear on cooling. This is what about Bence-Jones proteins. Next, about CML. In CML, the definition is it's a myeloproliferative neoplasm, MPN means myeloproliferative neoplasm, characterized by increased proliferation of granulocytic cell line without loss of their capacity to differentiate. There is no loss of differentiation here, whereas in AML there is a differentiation loss, whereas in CML there is no differentiation loss. Okay. On the pathogenesis, we are going to tell about the translocation of 922. BCR ABL fusion transcript formation. Okay, there is some component formed, that is BCR ABL fusion transcript formation. Because of this formation, there is a constitute activation of tyrosine kinase. It is a growth factor signaling pathway. Tyrosine kinase is a growth factor signaling pathway. Because of this activation, there is a myeloproliferation and CML is caused. Okay, what is the cause of disease? The course of disease, basically CML occurs in 3 phases. First phase is chronic phase, accelerated phase and blast crisis. In case of chronic phase, the blast count is less than 10%, whereas in accelerated it is more than 10 but it does not cause 20%, whereas in blast crisis you are going to see more than 20% of blast cells. In accelerated phase, you are going to see basophilia and massive splenomegaly. What are the clinical features? In old age, it is presenting in old age because it is chronic. Old age, fatigue, weakness, weight loss, anorexia, massive splenomegaly, bleeding gums, and bone pains in the later stages. Okay, bone pain in the later stages. Lab diagnosis, you are going to draw the peripheral smear. In the peripheral smear, it is called as garden party appearance because the slide looks very dirty. It's called as garden party appearance. There is some garden party, so many things is happening inside a party. So you're going to see normal RBCs, metamyelocytes, promyelocyte, myelocyte. These are all the precursors of WBCs. All these are seen. Since there is no lack for differentiation. Then eosinophils, neutrophils and band forms. These are all seen. And there is a normocytic normochromic anemia. On bone marrow, you're going to see the hypercellularity because the bone marrow is working more, and there is increase in the myeloid to erythroid ratio. The normal ratio is 3:1, and you're going to see the pseudo Gaucher cells, that is tissue wrinkled pattern which you learnt in biochemistry, and neutrophil alkaline phosphatase and LAP lab score is decreased here. FISH is the investigation of choice to look for the translocation. So after looking for the translocation, if it is positive, we are going to give a tyrosine kinase inhibitors, that is imatinib mesylate, and if the translocation is negative, we are going to do directly hematopoietic stem cell transplantation. Next, last part we are going to deal is AML. Last part is AML. So in AML, what is the definition? Group of clonal neoplastic proliferation of hematopoietic stem cells caused by oncogenic mutations that result in accumulation of excessive myeloblasts. So there is excessive myeloblast formation because of some oncogenic mutations. Pathogenesis, basically there is alteration in signal transduction and there is alteration of transcription factors. These are the main culprits here. So if there is a abnormal signaling transduction, then it will lead to inappropriate signal transduction and inappropriate gene expression because of abnormal transcription factors, and it is interlinked, and because of this what happens is there is increased proliferation of myeloblasts and there is decreased capacity of their apoptosis and blocked differentiation. These myeloblasts will not become future WBCs and they get blocked there itself. So myeloblasts are increased here basically. What are the clinical features? Pallor, fatigue and bleeding tendencies are very common here. Bleeding tendencies are very common, and hepatosplenomegaly. So here the risk factors you must remember, that is benzene and radiation. These are the risk factors. FAB classification, it is a 3-marker question. M0 to M7 basically. M0 is AML with minimal or undifferentiation. Okay, next is M1, that is AML without differentiation. There is no differentiation itself. M2, AML with maturation. M3, acute promyelocytic. M4, acute myelocytic. M5, acute monocytic. M6, acute erythrocytic. M7, acute megakaryocytic. Next, lab diagnosis. In case of lab diagnosis, the peripheral smear is important here. Before that, you are going to see the CBC. RBCs are reduced. That is HB count is reduced, and lymphopenia, total leukocyte is reduced, and the platelets are also reduced. Thrombocytopenia. MPO is positive here, being a myeloid origin, myeloid cell origin, it is MPO positive. The peripheral smear, you are going to see more than 20% of myeloblasts. On bone marrow also you are going to see more than 20% of myeloblasts. And the what is specific here is R-rods and phagots. On the peripheral smear you are going to see the R-rods and phagots, R-rods and phagots, R-rods and phagots. If they are singly arranged, they are called as R-rods. If they are arranged in groups and they are in crisscross pattern, they are called as phagots. Basically these are seen in case of AML type 3, okay, subtype M3. You are going to see this maximum. So what is the treatment for them? In case of AML M3, because of PML RARA mutation, you are going to give ATRA, that is all trans retinoic acid and arsenic trioxide is a treatment in case of AML subtype M3. They are going to ask what are these R-rods. Because of some translocation 15-17, there is PML RARA alpha fusion. So this is called as PML RARA mutation. Because of this, there is a decrease in vitamin A. This vitamin A it is required for the conversion of promyelocyte to metamyelocyte. So there is no conversion now because vitamin A is deficient. There is increase in the promyelocytes. After these promyelocytes are increased, they lead to the formation of increased R-rods. They are called as hypogranular cytoplasm, and phagots, that is crisscross R-rods. Okay, this is what about R-rods and AML. So in this 45 minutes to 1 hour module, we have discussed the main things which you are going to concentrate in hematology. So I feel it helpful for all people. Thank you.